Hello, I'm Victoria Werth, and I'm going to be introducing our speakers for today for the on-demand version of this webcast. I was out the day of the re initial recording. And I want to introduce the faculty. I'm Professor of Dermatology and Medicine and Chief of the Division of Dermatology at the University of Pennsylvania. Professor Chasset is Associate Professor of Dermatology at the Sorbonne in Paris. Professor Chris Richardson is Associate Professor of Dermatology and Rheumatology at the University of Rochester in New York. And Professor Ben Chong is Professor in the Department of Dermatology at the University of Texas Southwestern in Dallas. So just a few housekeeping items. Attendees will be on mute for the duration of the meeting. Questions to speakers can be submitted at any time through the Q&A. If you have any questions or are experiencing any technical difficulties, please use the chat box. And participants who attend the webinar in full and complete the post-event survey will receive an accreditation certificate. So our learning objectives today are to understand the key challenges in diagnosing CLE, explore current and emerging therapeutic strategies, and address unmet needs to improve patient outcomes. Our goal is to understand the complexities of CLE diagnosis and its place within the lupus spectrum, to evaluate the current and emerging treatment landscape for CLE, and to identify and address unmet needs in CLE patient care. So the agenda is going to be first, understanding CLE diagnosis and challenges by Dr. Richardson, then current and emerging therapies in CLE by Professor Chasset, and then addressing unmet needs in CLE patient care with Professor Ben Chong. And there will be a Q&A at the end. Professor Chong will be moderating the rest of this discussion, and we look forward to the first presentation by Dr. Richardson.
Great. So it's great to be with you, everyone. Very grateful to Dr. Werth for the invitation to speak to you today about something I'm very passionate about, which is diagnosing cutaneous lupus. I do receive some industry funding for some research and such, but I'm not talking about therapeutics in my talk, so none of it's directly relevant today. So I'll give you a quick overview of cutaneous lupus and classification. We'll spend most of our time on the physical exam, which is really, really key for diagnosing cutaneous lupus. I'll touch a little bit on associated serologies and then have a few slides at the end about histopathology to wrap things up. I do have some photos of patients from my clinic, so I want to say thank you to them for allowing me to use their photos for teaching. And it really is all in the spirit of helping us understand and know lupus so that we can help our patients with lupus. Okay, a little overview. So this is the classification system that was developed now a number of years ago, but we still generally use for cutaneous lupus, developed or called the Gilliam criteria or Gilliam and Sontheimer criteria. And you can see it's divided into two categories, and I don't want you to try to read through all of the little subcategories on here. But generally, on the right here, we have lupus nonspecific skin disease. These are things like hair loss or calcinosis cutis or Raynaud's phenomenon, things that can be associated with lupus, but are not specific for lupus. And then on the left, you have what we consider lupus-specific skin disease. And this classification criteria groups lupus-specific skin disease into three big categories. And that is acute cutaneous lupus, subacute cutaneous lupus, and chronic cutaneous lupus, which has several subcategories itself. And here you see some classic examples of each of those three types of cutaneous lupus. You have the malar rash or butterfly rash of acute cutaneous lupus, the scarring, hypopigmented plaques on the scalp, and especially in the conchal bowl of discoid lupus, which is the most common form of CCLE, and then these red annular scaly plaques on the upper extremities, upper trunk of an individual with subacute cutaneous lupus. We'll go through all of this in detail here in a minute. But before that, I thought it would be nice to think about how each of these types of cutaneous lupus are associated with systemic disease. And so here On the right, again, you have SLE or systemic lupus, and on the left, you have cutaneous disease. And the first thing to note is ACLE is a manifestation of systemic disease. And that's going to be very helpful as you're trying to distinguish, is that malar rash part of lupus or not? So ACLE, the malar rash, but also can be more widespread, a subset of SLE. Discoid lupus, you see, is the largest or most common form of cutaneous lupus. Most of the time, not associated with systemic disease, but sometimes it is. You see the overlap in the middle. And SCLE comes in third and can be associated or not with systemic disease. The other forms here, like neonatal lupus, pretty rare. It's similar to SCLE in that it shares the same autoantibody profile. It can have systemic disease that can be severe. We'll touch on that. Lupus paniculitis, or abbreviated here LEP. Tumid lupus, or LET, and hypertrophic lupus, or LEH, all forms of chronic cutaneous lupus that are less common. And we'll show you examples of all of these forms of skin lupus. Now, I think it's pretty hard actually to see or to tell if something is cutaneous lupus from one zoomed in view of a single lesion. It's really important to see the distribution of lesions to make an accurate diagnosis of cutaneous lupus. So here you see some examples of the distribution of different forms of cutaneous lupus. We talk about the butterfly rash of ACLE, but it can be more widespread, for sure. Subacute cutaneous lupus favors the upper trunk, upper extremities. It's rare to have it on the legs unless perhaps it's drug-induced. That would be more common. It can extend up onto the head and neck, but really you're looking at upper shoulders, chest, upper back for distribution of SCLE. These are both in photosensitive distributed areas and favor extensor surfaces on the arms and legs. The other forms here are less common, like tumid lupus, similar distribution of SCLE, even more upper chest, upper back, upper shoulders, and head and neck. Lupus paniculitis tends to favor areas with more subcutaneous tissue. Discoid lupus, most of the time, is going to be on the head and neck, as shown here, but it can be below the neck sometimes, and we call that generalized. I'll show you some pictures of that in a bit, too. And chilblain lupus, of course, is on the fingers and toes. So keep in mind the distribution as you're thinking about different forms of cutaneous lupus. And now let's see some examples. So here are a couple of my patients. They have the classic malar rash associated with systemic lupus. This patient here on the left, more prominent. The patient on the right, pretty subtle, right? Could be easy to miss. And you can see many different severities of acute cutaneous lupus. Sometimes it's very, very red and scaly and maybe even a little thicker, and other times it's just a blush of erythema. But you see the common features here. The malar cheek, really defined by the lateral canthus of the eye down to the corner of the mouth and the nasolabial fold. This triangle is the malar area. The erythemas and plaques are going to spare the nasolabial fold. That's a really classic finding in cutaneous lupus, but you see it on the malar cheeks and over the bridge of the nose, but it can be in other areas like the chin and the upper lip of this patient. Actually, both patients have some on the chin. Other things you might see in cutaneous lupus are lip crusting. That's been described. Now in Rochester, it's snowing right now. It's the winter, the heat's on. Everybody has lip crusting. Not really helpful for distinguishing ACLE from every other person walking down the street. But sometimes it can be helpful, and you'll see that if you're looking for it. The rest of the rash, sometimes called an extensor dermatitis because it can go down the arms, onto the hands, and classically spares the knuckles, which is in contrast to dermatomyositis, which might be on your differential diagnosis, which usually involves the knuckles. I should go back real quick. And so the serologies associated with ACLE are going to be the classic ones associated with systemic disease. So on this facial rash differential, we talked about dermatomyositis, but rosacea should be at the top of your list. It is the most common photosensitive malar rash, but you're going to need to ask the patient things about when it flares, how long it lasts, right? Does it flare with alcohol or chocolate or caffeine, those kinds of things? Are there associated papules or pustules? Those are all signs of rosacea, and it's going to come and go a little more quickly and flare more rapidly after sun exposure than ACLE. Photoallergic, photodrug, much less common. But then other things that aren't necessarily photosensitive, but very common to keep in mind are your sebderm, atopic derm, contact dermatitis, and of course, some physiologic flushing. And always remember, this is a manifestation of systemic lupus. So be asking questions to help you make that diagnosis. SCLE, or subacute cutaneous lupus, most often presents as these red, scaly, annular plaques. Again, upper chest, upper back, upper extremities. They sometimes have some central clearing, like the patient on the left. Other times, not so much, like the patient on the right. And they don't have to be perfect circles. We call it annular, but it can be pretty irregular annular plaques. It's usually associated with anti-Ro or SSA antibodies. Some might say that so much so that if they don't have anti-Ro antibodies, you might consider other diagnoses. I don't know that that's entirely true, but it's most of the time. And most of the time it has this annular configuration, about 2/3 of the time. But about 1/3 of the time, it just presents as papules. Same distribution, same response to treatment, same basic histology and morphology, except that they're small papules instead of large annular plaques. But don't forget this form. It's often forgotten when we're looking for a diagnosis in these patients. And then very important to remember is that about 1/3 or so of subacute cutaneous lupus is drug-induced. So the most common culprit in my practice are proton pump inhibitors or PPIs. They certainly are very commonly prescribed here. HCTZ and terbinafine are classic examples of drugs that can induce SCLE, but also other antihypertensives and antifungals and TNF inhibitors. These are the ones I keep in mind. Everything else I look up. There are probably many other drugs that can cause SCLE, but it's classically anti-Ro positive, just like regular SCLE, and it's antihistone negative in contrast to other forms of drug-induced lupus. And I have a picture of the legs here as opposed to the other pictures I've shown you, because that to me is a tip-off that I should really look for a potential drug culprit. It's not that common to have SCLE below the waist. And that's, here's one little paper that shows that widespread involvement, which really was plaques below the waist, had a high odds ratio in favor of being drug-induced. And other things they point out here are what I would just lump as atypical lesions. Are they bullous? Do they look like erythema multiforme? Are they a little vasculitic? Something that's unusual from your run-of-the-mill SCLE, look for something, look for a drug that might be inducing that. And now we have discoid lupus, which is the most common form of lupus, cutaneous lupus. Here, this is the same patient, 2 different time points. And I want to make a few points about this from this patient. So number one, when I'm talking to folks with discoid lupus and other forms of chronic cutaneous lupus, I talk to them about activity and I talk to them about damage. Activity are things like erythema and scale and symptoms, sometimes tender, sometimes itchy, whereas damage has to do with hypo and hyperpigmentation and scarring. And so in this individual, you see some areas, like up here on the scalp, which are hypopigmented and scarred with some peripheral hyperpigmentation. This is all damage. None of this is active. Whereas here on the cheeks, you can see it's very active. Little induration, it's pink. And so that's the area you want to focus any topical treatment on. Fast forward some months later, you can see that her cheeks are no longer active. So she has more hyperpigmentation, that's common, but she's left with these hypopigmented scars afterwards. So always important to consider that a patient can have a mix of active and inactive lesions, and helping them to understand what to treat is very important. Also a note about that hyperpigmentation. So you might read classically that there's this peripheral rim of hyperpigmentation like you see in this picture on the right with central hypopigmentation and scale, but that really depends on the degree of baseline pigmentation of the patient. So in a patient with a lot of melanin in the skin, they're going to have a lot of peripheral hyperpigmentation from that inflammation. But in a patient like the one on the left, where they have very little pigment in the skin, they're not going to have that kind of classic peripheral hyperpigmentation, at least not to the same degree. Whereas the histology and the rest of the presentation is going to be very similar. And here are a couple of my patients we put out in a case series. These two happen to have generalized discoid lupus. And you can see, a lot of scarring, erythema, scale for both of these patients. This gentleman has it on the chest and shoulders and arms, and this lady has it more on the dorsal hands and arms. But one thing I want to point out here is it's going to be pretty rare to have generalized discoid lupus, which is discoid lupus below the neck, without also some involvement on the head and neck. If someone were to say, I've got this one lesion on the leg and I think it's discoid lupus, I would probably say no. It really needs to be generalized, and that includes the head and neck. Tumid lupus, fairly common. I see this quite a bit, but not nearly as common as the other three I've shown you. This is what I call dermal lupus. All of the inflammation is in the dermis. And like other skin conditions where the inflammation's in the dermis, this just pushes up the skin to form these non-scaly, smooth plaques. They're often annular, face, neck, upper chest, shoulders, arms. Not typically associated with systemic disease. Usually serologies are negative, as you can see in these three patients, or maybe a very low titer ANA. And this is the most photosensitive form of cutaneous lupus. And then you've got lupus panniculitis and lupus profundus, sometimes lumped together. You'll see that in the literature quite a bit, but you can tease them apart. Lupus panniculitis is really inflammation that only involves the fat. And so when you have the subcutaneous tissue affected, it atrophies and you get these indentations in the skin, and they're smooth because it's not involving the epidermis. You might have a little erythema, as you see here, but generally when it's active, you know because it's tender. So I'm always asking my patients, what parts are tender when I'm thinking about treatment? Lupus profundus, on the other hand, I sometimes call full thickness cutaneous lupus because you have inflammation from the epidermis through the dermis down into the subcutaneous fat. So you get that atrophy or indentation, but within that, you have what otherwise seems like discoid lupus. And then this variant, which is more rare than the others I've shown, hypertrophic lupus, it's another form of chronic cutaneous lupus. And I've at least seen it in at least a couple of different morphologies, although there are several. The one on the left looks a lot like tumid lupus, but it's scaly on top. So you know that that's not true dermal lupus or tumid lupus. The patient on the right looks more like discoid lupus, except it's really thick and very indurated. So there's a couple of ways the hypertrophic lupus can present. The key really is the histology, and I'll show you that here in a couple minutes. Bullous lupus is another form of cutaneous lupus I wanted to touch on. This, again, is from Richardson, this classification system. Again, there's non-specific bullous disease with lupus, and there's lupus-specific skin disease that is bullous. And it can be many different types, and that's because if you have enough inflammation at the dermoepidermal junction, which is classic for cutaneous lupus, you can have a split, and you can have a vesicle or a bulla. and it can be really robust and be TEN-like, or it can be less so and be more vesiculobullous. But all forms of cutaneous lupus could potentially have enough inflammation to cause bulla or vesicles. Here's a few examples from my patients. Here you have a classic SCLE, erythematous pink annular plaques on the back in this V-shaped distribution, which is really common, but it's studded with tiny little vesicles. So this is vesiculobullous SCLE. Here's a woman who, like many people in Rochester, goes south for vacation in the winter, and she had, as you can see, a very photosensitive rash in every other way, like SCLE, Rho positive, high titer, ANA positive, but these large bulla, like you can see it's in the inset. And this is a TEN-like SCLE presentation. And then this poor lady here on the right has very bad systemic disease that becomes bullous when it's active on the skin, along with all of the other systemic manifestations she has. So she has bullous ACLE. Neonatal lupus is really a form of newborn SCLE from maternal transfer of antibodies, specifically anti-Rho antibodies. That in and of itself is not so bad, but it can lead to heart block, hepatobiliary disease, or cytopenias. So they need a full systemic workup to rule those things out. And here's a patient of mine. I don't have a newborn picture, unfortunately, but it favors the head and neck, which is a little different than other forms of SCLE. And so you see these erythematous plaques on the scalp. I saw her actually for the first time at 2.5 months. We gave her a little topical steroid, and you can see how she gets better over time. And she did not have any of the systemic manifestations. So as those maternal antibodies kind of wash out of the system, they get better. Okay, last couple slides, we'll go through a little histopathology and then I'll wrap up. All the red dots in these different diagrams are to indicate lymphocytic infiltrate. It's largely T-cell infiltrate. And you can see it's pretty mild in ACLE. You'll get some vascular dilatation up towards the surface, which helps contribute to the redness. But it's a fairly mild form histologically of cutaneous lupus. SCLE, very similar, but more robust. Discoid lupus also has a dense, deep lymphocytic infiltrate, often around glands and hair follicles, and we call that periadnexal. Tumid lupus, as I said before, is really about the dermis. These little blue squiggles are mucin, but that's where the inflammation is for tumid lupus, and lupus paniculatus down in the fat. And just some examples of that, histologic sections. You have the dermis down here, the little purple blue dots are lymphocytes, mostly T cells. These little circles, open circles, are the vacuoles, and the interface dermatitis or vacuolar interface dermatitis of lupus. Here, more lymphocytic infiltrate, more robust interface dermatitis and SCLE. In discoid lupus, you get these dense aggregates of T cells and B cells that form around hair follicles and blood vessels. Some follicular plugging can be quite prominent. And in tumid lupus, you see something similar, but it doesn't involve the dermoepidermal junction up here at the top, and it's often filled with a lot of mucin. And lupus paniculatus and profundus, this is lupus profundus. You see these dense aggregates of lymphocytes in the fat, but you can tell it's lupus profundus because you also see it in the dermis, and you also see it up along the DEJ. And with that, oh, I have one more slide. I forgot. And this is hypertrophic lupus. And at first glance, you might say, well, that looks like a squamous cell cancer. And that's kind of what it looks like. And so you really need an astute dermatopathologist to look at this maybe squamous cell cancer at the top, but look underneath and realize this looks just like discoid lupus with these dense perivascular and periadnexal lymphocytic aggregates. And pair that with your clinical, and you get a form of cutaneous lupus called hypertrophic lupus. And with that, I'll end. So thank you very much for having me. I'm sorry I won't be able to be here for the question and answer period, but everything I've learned from the other people on this panel just about, so that I'm sure they can handle any of the questions that come my way. So thank you again.
Thank you so much, Dr. Richardson. That was great. It was a very thorough presentation of all the different different types of cutaneous lupus, and it was a really nice overview. So thank you. I think we're going to move on to Dr. Francois Chasset, who's going to be presenting on current and emerging therapies in cutaneous lupus. And I think this is actually very apropos for him to speak on this because he's done a lot of work looking at various therapies and characterized kind of how number of patients have responded to different types of therapies. So somebody who's very well versed on this topic. So take away, Dr. Chasset.
Thank you, Ben. Hello, everyone. I'm very happy to be here with you to discuss current and emerging therapies in CLE. Here are my disclosures. I have been investigator in some CLE trials, but there will be no impact on my talk today. So today we will discuss current and emerging therapies for cutaneous lupus or CLE. The focus will be on existing guidelines and the importance of classifications. Then we will discuss current, topical, and systemic treatments and the strengths and limitations of these therapies. And we will finish with emerging treatments and how might they will change the standard of care of CLE. The ACR-EULAR 2023 therapeutic guidelines provide a stepwise approach to managing CLE patients associated with SLE. You can see that general measures are always appropriate, such as photoprotection, and then initial treatments involve topical agents, antimalarials, hydroxychloroquine or chloroquine, with systemic therapies reserved for more persistent cases. And compared with the previous 2019 EULAR guidelines, biological therapies, including belimumab or anifrolumab, are now recommended as second-line treatments, similarly to methotrexate or mycophenolate mofetil. As you can see, there are also specific guidelines for CLE. You have, for example, the British and the European CLE guidelines, which are based on expert opinion. As you can see, in all cases, antimalarials are recommended as first-line treatment in addition to topical treatments. Second-line treatments include methotrexate, as well as dapsone and retinoids, which are mostly used by dermatologists, not by rheumatologists or internal medicine physicians. And as you can see as well in these guidelines, biological therapies, for example, belimumab or anifrolumab, are not recommended since they are not specifically approved for CLE. And this is why accurate classification is essential in CLE management. As Chris said before, the different subtypes are not associated with the same risk of progression from isolated CLE to SLE. But you also have these ACR-EULAR classification criteria, which allows to classify patients as isolated CLE or SLE. And which is important, it is important to highlight that CLE patients may be classified as SLE by the presence of laboratory abnormalities, for example, cytopenia, low complement levels, or autoantibodies. And this is very important because these subtypes of patients may be eligible for biological therapy. So topical treatments remains a first-line treatment in CLE management, in particular for local disease or very mild localized lesions. As you can see in a recent systematic literature review performed until 2023, among 7 randomized controlled trials, topical clobetasol, nicotinamide, and tacrolimus seems to be more effective than placebo. In clinical practice, we often use topical corticosteroid and calcineurin inhibitors, and small randomized control study, including 20 to 40 CLE patients, showed globally similar efficacy between these two types of treatments. Some studies suggest that clobetasol may have higher efficacy on SQUELL, but may have a higher rate of adverse events, including telangiectasia. Of note, and I think this is the most important, in a randomized placebo-controlled study, topical tacrolimus showed that was better than placebo at improving CLE after 28 days, but not after 84 days. This suggests a potential decline in adherence over time, and I really think that long-term adherence in topical treatment is very low, which has already been demonstrated in other diseases such as psoriasis, which limits the use of topical treatments. And Chris showed us a lot of pictures of damage, and I really think that we need to prevent damage. So topical treatments are important, but you need to consider systemic treatments. Antimalarials such as hydroxychloroquine and chloroquine are widely used as the first-line treatments in CLE. As you can see in a randomized control study, including 103 CLE patients performed in Japan, hydroxychloroquine was found to be superior to placebo after 16 weeks, which confirmed its efficacy widely demonstrated in SLE. There is a current debate regarding the optimal dosage to balance efficacy and tolerance with hydroxychloroquine. Based on the EULAR and the American Academy of Ophthalmology recommendation, a dosage of 5 milligrams per kilogram per day of real body weight is advised due to the risk of maculopathy, but maybe a higher dosage is needed to achieve improvement. So what is the response to antimalarials in CLE? In a meta-analysis which included 31 studies and about 2,000 treatment lines, the pooled response rate was 64%. However, the response varied depending on CLE subtypes, with less favorable outcomes observed in childbearing lupus and lupus paniculatis. So in particular in lupus paniculatis, we need aggressive treatments. Sorry. For patients with persistent CLE, For patients with persistent CLE activity, it is possible to optimize antimalarials use. It is, for example, possible to monitor HCQ blood concentration with some thresholds that have been associated with non-adherence or CLE response. And it is also possible to switch from hydroxychloroquine to chloroquine or to add quinacrine, but quinacrine is not widely available. For cases unresponsive to antimalarials, second-line treatment such like methotrexate, mycophenolate mofetil, dapsone, and retinoids are recommended, as I said. However, as highlighted in a recent Cochrane review of randomized controlled trials, methotrexate demonstrated efficacy in CLE in only 2 very small studies, and the efficacy of methotrexate using Validated tools such as CLE was reported in only one study published by Vicky Werth with a CLE 50 response in only 46% of patients with DLE and 72% of patients with subacute lupus. Thalidomide is a highly effective treatment for refractory CLE. We used a lot thalidomide in France because it is recommended as second-line treatment since 2015 in a temporary recommendation for use. This treatment is highly effective with an overall response rate of about 90% of cases, with about 2/3 of patients achieving complete response. However, its use is limited by potentially severe side effects, with about 25% of patients which withdraw this treatment because of adverse events, with potentially severe adverse events, including the peripheral neuropathy and thromboembolic events. So it is very important to carefully monitor these patients, and this treatment is highly teratogenic, so an appropriate contraception is mandatory to treat these patients, and its high cost limits its use. Lenalidomide offers an alternative to thalidomide. As you can see in some studies from my group, in some small case series of about 40 CLE patients, lenalidomide was associated with about 88% with the CLASI 50 response and about 50% of patients reaching a complete response. And interestingly, there was no case of peripheral neuropathy, of worsening of thalidomide-induced neuropathy with this treatment, but there are some cases of thromboembolic events, and it's a very high cost, limits its use in a lot of countries. And in our studies, it is important to highlight that this treatment have no effect on extracutaneous SLE features. So now let's move to belimumab. Belimumab was the first biological treatment approved for SLE. So it is important to say that this treatment demonstrated the efficacy in SLE in 5 randomized controlled trials, which is huge in SLE. In clinical trials, belimumab demonstrated modest superiority over placebo in treating CLE manifestations, particularly DLE. However, for dermatologists, these trials are difficult to interpret since CLASI was not used, but in real-life cohort study, refractory CLE associated with SLE, CLASI 50 at 6 months for about 60% of patients, and data from an academic trials of Germany are pending. Anifrolumab, the new biological treatment approved in SLE, is a monoclonal antibody that targets and binds to the interferon receptor subunit IFNA-RAN. This treatment is administered intravenously at a dose of 300 milligrams per month, and in 2 phase 3 trials, anifrolumab demonstrated efficacy on active SLE features based on the BICLA response, with particularly interesting results using CLASI activity. The efficacy of anifrolumab was in CLE associated with SLE was confirmed in real-life prospective small case series, and in a study from early access program in France, in UK, and in the US. These reports indicate very rapid efficacy across all CLE subtypes, with a similar safety profile observed in the real-world setting, in particular an increased risk of viral infection, in particular herpes zoster, so vaccination is very important. Just to illustrate a typical example of a patient in romaniforlimab was initiated early as a second-line agent due to the risk of definitive cicatricial alopecia. And you can see that this treatment showed very impressive improvement in the regrowth of hair, with a very important improvement of the quality of life. Then a few words about some emerging treatments or recent advances in the understanding of CLE pathogenesis have led to novel therapeutic approaches. The most recent findings highlight that several type 1 interferons are involved in CLE pathogenesis, not only interferon alpha, and some very interesting studies, in particular some performed by Vicky Werth, showed that plasmacytoid dendritic cells are not the main interferon alpha producing cells, and that keratinocyte, but also CD16 positive DC or CD14, CD16 positive macrophages may also produce type 1 interferon. And finally, although a significant B cell signatures is observed in CLE, particularly in discoid lupus, B cell targeting therapies are disappointing in CLE. So regarding emerging topical treatments, topical JAK inhibitors, in particular ruxolitinib, have been shown in some case report to be a potential treatment for localized CLE, and an academic CLE trials performed by the team of Chris Richardson are pending. Regarding some future study, phase 3 trials for anifrolumab in CLE are currently underway. These stage 1 and stage 2 trials will focus on patients with CLE with high disease activity, with inadequate response to antimalarials, glucocorticoid, or immunosuppressive treatment. Importantly, in the US, the primary endpoint will not be the same than in Europe, with a new tool, which is the CLA RGAR, which will be used as a primary endpoint, and the CLASI response will be used in Europe. The iberdomide, which is a thalidomide analog, has shown efficacy in the phase 2 trials in SLE. However, in this trial, the CLASI 50 score was not significantly better than placebo, which was disappointing. However, recent publication by Vicky demonstrated improvement among patients with discoid or subacute CLE, and the phase 3 study will be necessary, I think, to draw definitive conclusions. JAK inhibitors have gained interest in the treatment of such conditions such as lupus, in particular CLE. And if you want to target type 1 interferon, it is interesting to target TYK2. And you have some TYK2 inhibitors, such as the cravacitinib, which is a potentially very interesting target in CLE. Indeed, the cravacitinib has demonstrated efficacy in SLE in a phase 2 study. And in this study, as you can see, the CLASI 50 response was about 69% in the treated groups, compared with only 16% in the placebo group. And the phase 2 CLE trial in CLE have been terminated, and we will have the results soon. Litifilimab, which is an anti-BDCA2 antibody, was the first treatment to show positive outcomes specifically in CLE through phase 2 trials published in the New England Journal of Medicine. This drug specifically targets plasmacytoid dendritic cells, which are involved, like I said, in the CLE pathogenesis, although there are some debate currently. There is an ongoing phase 3 trials, which will provide further insights to its potential as a future standard of care for CLE. Just a quick word, because there have been a press release recently for the dapirolizumab pegol, which is an anti-CD40 ligand, which had recent positive announcement of a phase 3 study in SLE, which are not published, but in the phase 2 study, there was better improvement in CLE compared with placebo. So this treatment may be interesting. And many, many more to come. There are a lot of treatments which are currently developed. It was not possible to detail everything, but I think the daxdilimab, which is an anti-PDC, empatteron, afimatoron, which are anti-TLR7 or 7/8 inhibitors, some T-cell engager, maybe the futures of CLE. And I would like to finish with a future academic CLE trials, which will compare in France lenalidomide versus methotrexate in CLE, which was recently funded by the French Ministry of Health. And thank you very much for your attention. I look forward to discussing with this exciting this development further. Thank you very much.
Thank you very much, Francois. That was great. I think you nicely really had a nice overview of what's currently out there, but also had some really fascinating slides that really highlight what's to come in terms of cutaneous lupus treatments. And so thank you very much for that very thorough presentation. So I'd like to conclude or round up this Excellent Lupus Forum by talking about unmet needs in patient care. And before I do that, I also just want to again thank our sponsors, CESUS Medical, and then also University of Leeds for also putting this all together. So thank you again for doing that. Okay. Now I'm going to make sure I can do this with the slides. Let's see. Okay. Here are my disclosures. I think that these disclosures are actually, fortunately, not relevant to what I'll be speaking about. So I'll be talking a little bit about treatments for disease damage, which is something that is somewhat limited in terms of what we can do for that. I'd like to talk a little bit more about diminished quality of life, and then finally talk about the kind of an overview, a little bit about just how there's been some difficulties of evaluating severity of skin disease, but there are emerging measures that are doing better in terms of looking at assessing this as well for cutaneous lupus. So in terms of disease damage, I think this has been mentioned by Dr. Richardson about how this can occur in this with signs of dyspigmentation, where we mean by that, as you can see, changes of pigmentation where there's hyperpigmentation or hypopigmentation is mentioned, as you can see in these photos, that don't go away, and they can be accompanied often with scarring or loss of hair follicles that can be also disconcerting for patients as well. We are really unfortunately limited about treatments to really reverse that, because there's unfortunately not good insufficient treatments that can actually reverse this process. We have found that actually disease damage is actually probably more striking in blacks. And so we've been able to look at patients with discoid lupus who are black and non-black. We've had about 100, roughly close to 100 in each group, where we looked at them retrospectively. And patients who were black and had discoid lupus were more likely to have pigmentary changes, particularly in the scalp and ear. And they also had higher rates of scarring alopecia, as mentioned, as you can see on the right-hand graph as well. Okay. So as I kind of mentioned before, the current treatments right now don't really treat damage well, but they do a pretty good job looking at helping with activity. And so this is just an example of a patient of ours who actually had pretty severe discoid lupus, where you can see pretty striking erythema and scale, but she also had features of disease damage of scarring and pigmentation. And so lenalidomide did a nice job reducing the erythema and scale in this patient, but you can see that the pigmentary changes and the scarring still remain in this patient, and it still does, even as she is currently still on lenalidomide. So in terms of what we are currently do and advise our patients on how to deal with disease damage, we typically talk about what to do in terms of treating the dyspigmentation scarring. Now, there are sometimes some bleaching creams that people ask about and want to try, and so we can offer those that have these are hydroquinone-based products. But I do tell patients that that the likelihood of this working is pretty low. But some patients prefer to try something, and they want to try something for at least 3 to 6 months to see if there's any benefit. Um, so I'm usually okay with giving that. We do recommend actually that patients try to use high coverage makeup, and so they can be makeup that actually can be custom made to fit the patient's skin tone. So some patients will be able to go to local stores and actually try on different. Now there's actually products that can come that have different skin tones that you can try on to match match the skin tone that actually best, match the skin tone for the patient as well. And so that can be very helpful for patients, especially if they're going out for social settings or just kind of on a regular basis. That can be very helpful for them. For our scarring alopecia, usually we discuss mechanisms to help cover up that, usually with wigs. Most patients do actually find ways to find a custom fit wigs. They can also cover by wearing hats as well. And then we also go through gentle hair care practices, especially trying to avoid hairstyles that can further pull out hair, like cornrows or braids as well, to try to minimize that damage as well. So in terms of treatments, other treatments that have been mentioned as well for disease damage, this is a figure that kind of summarizes the different types of treatments that have been done. Hair transplantation has been can be used sometimes in settings of scarring alopecia. Laser therapy has been also considered, along with dermabrasion, to treat scarring. And then there's been melanocyte transplants, which have been also used to try to treat pigmentation, cherry changes. Fillers and fat grafts are again used for areas of very profound atrophy, particularly in patients who have lupus paniculitis, where they are often left with these very severely atrophic plaques as well that can be disfiguring as well. So in terms of laser treatment, they've been, I think there are a couple of subtypes have been used to treat different aspects of scarring. So scars or atrophy can often have a lot of erythema or significant erythema that can actually be treated with specific lasers. Primarily intense pulse light and pulse dye lasers have been used. Just the caution with those lasers is post-inflammatory hyperpigmentation. ND-YAG and CO2 lasers also could potentially be used to reduce scarring by helping remodel collagen. But again, the side effects can be hypopigmentation and erythema. This picture here is just an illustration of a combination treatment of ND-YAG and IPL laser. So one treating scarring, one treating the erythema that eventually improved that improved both sides as well. I would probably caution in using this in patients who have active skin disease. So I usually recommend for patients in general to be stable for about a year before considering these type of treatments, especially because lasers, you worry that any sort of laser could cause trauma and also can theoretically actually cause new lesions to occur. So you do want to be careful with that. Fillers have been something that's been used for atrophy. So I kind of mentioned before that lupus paniculitis patients can be often left with these very atrophic lesions. And so fillers, most commonly the ones used are actually ones containing hyaluronic acid or polyallolactic acid. And they can be usually injected in the deep dermis or the subdermal periosteal junction. They often do require multiple injections. And then they usually also, most of the time, do not last. They can be lasting for about 6 months or so, 3 to 6 months or so, and they need repeated injections. And again, this is just an example of a patient. This is done by my colleague, Dr. Heather Goff, who actually did with lupus paniculitis, who had polyallolactic acid injections that to the cheeks areas, as well as the the maxillary and the zygomatic cheek areas as well. And she received 3 sets of injections where you could see some notable improvement in her atrophy as well. And again, I would wait at least a year for disease stability before you would consider doing these injections or filler treatments. The side effects, again, are bruising, swelling, and erythema. So moving on to quality of life concerns, this is actually really something that has deeply impacted, this disease has deeply impacted patients as well. And that can be from both acute parts of their skin disease, where they can get really bothersome symptoms like itching, burning, swelling, followed by symptoms or signs that from chronic disease where they get the dyspigmentation, the scarring, the hair loss, the atrophy as well. And so that can often cause problems with them interacting with their friends and families. They often have become more self-conscious. They're not as, they have less confidence in going out to find a job. They're worried about their disease getting worse all the time. And this obviously can lead to mental health issues as well, where patients are at higher risk for depression and anxiety as well. So, we've had the chance to be able to interview some of these patients a little bit more in depth to try to understand what they are dealing with. And so we were able to have some interviews, more focus group interviews with patients who are deeply impacted with cutaneous lupus. And you can see how patients, this is just a testimonial from one of our patients who was able to spend a lot of time outdoors, but couldn't spend any time outdoors now because of her skin issues as well. And that's kind of impacted their quality of life. This second testimonial was actually one where this actually affected how she interacted with others, where people were afraid to even interact with her in a normal fashion as well. And so that is something that is very common for patients with cutaneous lupus to face as well. There have been good quality of life studies looking at patients with cutaneous lupus. So this was done by Vicky Werth's group, where they compared quality of life with cutaneous lupus patients with other common skin diseases as well. And cutaneous lupus patients, in this case, didn't score very well in their quality of life as well. And they're among some of the more serious ones. And so these are scores. These are actually quality of life scores that are based on the Skindex, which is a generic skin disease quality of life questionnaire. And so the higher the scores, the worse they are off in terms of their quality of life here. And so in terms of just the individual questions that are asked, some of the more severe symptoms that people complained about was burning and stinging. And actually, interestingly, water, or actually, this should be actually really showing that the skin itches. This actually is not, the box is not this is highlighting not the correct things, but it should be highlighting that the skin itches and can get very irritated and sensitive commonly as well. And then patients often worry a little bit about their skin getting more serious and then getting worse as well, as we mentioned before. So in terms of kind of addressing quality of life concerns, we talk a little bit about how they're dealing with in terms of their acute symptoms. So we ask them about itching and burning and give them additional medications to help with some of their symptoms in terms of itching and burning, and then also ask them about issues that are related to chronic and what they're doing to try to help deal with some of the alopecia and dyspigmentation concerns as well. We also talk about the importance of patient support groups, and and that can also um, be very helpful for patients to be able to freely express how they're feeling as well, and have people who are living with similar conditions to be able to empathize with what they're doing and give encouragement and suggestions as well. We've also encouraged family and friends to be involved in their care, and so it's usually always helpful to have a family member with them at their visit, but if they don't have one, to encourage them to have one to come to their visits so they can be engaged and understand what they're going through. And then also consider specialist referrals like psychiatry if there's concerns of mental health, and then also even with smoking cessation that can be very helpful too with their health too. But it can be pretty overwhelming to address all these concerns in one visit. So perhaps having goals or limited, focused goals in mind to address one or two of these issues could be very helpful for patients. And that's per visit as well. I do want to just conclude about just some kind of giving some historical context about clinical trials in cutaneous lupus. And so I think, really in the earlier clinical trials in cutaneous lupus have been really limited, partly because of just the design. There weren't very many randomized controlled clinical trials, and there weren't actually a lot of validated outcome measures that were used to look at skin severity. It was actually oftentimes usually subjective in nature. Patients were determined if they looked better or worse just by how providers saw them. So there wasn't really validated measures that were where scores could be ascribed to measure disease severity. And then there was actually really a lack of patient-reported outcome measures where patients could really say if they felt like they were doing better or worse with the treatments they were given as well. So what's been emerging, I think, in the past 1 to 2 decades is actually the use of validated skin disease severity scores, which I think have accelerated the progress of clinical trials in cutaneous lupus. And primarily that's been through the CLE, which I'll briefly talk about, and then also more recently there's this another outcome measure called the CLE IGA that's also been used in clinical trials as well. And then the emergence of more specific patient-reported outcome measures for cutaneous lupus, mainly the cutaneous lupus erythematosus quality of life. So the CLE is actually a validated skin severity measure, and that there's 2 scores that are given, one for activity that assesses for erythema and scale and damage, which then looks at dyspigmentation and scarring. And they actually also look at different parts of the body as well. So they'll actually, so the rows are actually scored for each part of the body, and there's heavy weighting for the head and neck because there are more lesions that usually are found in the head and neck region compared to other parts of the body. And then the columns relate to the presence and extent, or I guess presence severity of different signs of activity like erythema, scale for activity, and then pigmentation and scarring for damage here as well. And so this is just kind of what the CLE looks like a little bit more closely. And then there's a special section for looking at alopecia, where there's alopecia that's non-scarring alopecia that's due to inflammation in the scalp, and then there's scarring alopecia that's more related to damage. So the CLE has been, as you can see, I think is also mentioned frequently by Dr. Chasset, has been more frequently used in more recent trials. And so prominently, I think I wanted to illustrate one trial that was used to actually, that was a randomized controlled trial of hydroxychloroquine versus placebo in cutaneous lupus. And so with this, the CLE score showed that using the CLE score in these patients, both the hydroxychloroquine group and the placebo group, now these were patients who actually were on background lupus medications, both improved. over time as well. And that also, but there wasn't a big difference between one group versus the other as well. The CLE IGA, which is a cutaneous lupus activity investigator global assessment, is a 5-point Likert scale that evaluates the severity of different sides of CLE disease activity. So it looks at different signs that are seen in lesions as well. And so this is actually kind of modeled off other IGA scores for other skin diseases as well. The idea is that for patients who really truly respond, there's been a kind of a recommendation in the past of reaching a score of 0 or 1 where they're clear or almost clear in all these signs here to reach kind of therapeutic efficacy as well. And then finally, I wanted to just explain the CLE QOL, which is a disease-specific quality of life questionnaire that we've created as well and then validated in a cohort of CLE patients. And so this is actually modeled after using the SkinX29, which actually asks for frequency of difference frequency of different things that can occur in people's lives in the past 30 days that affect their quality of life. And then we also added kind of more specific questions related to cutaneous lupus that were related to photosensitivity, alopecia, and pigmentation changes as well. And this, in our cohort study, showed excellent reliability and content validity as well. So this is just an example of how this works, where you could see that patients are asked about these symptoms or functions or issues with functioning, and ask them how often does it occur in the past 4 weeks, and then you can see that the more frequent it occurs, the higher the score that they get as well. So just in summary, we have gone through current unmet needs that include treatments for disease damage that we do need to work on as well. There's certainly quality of life issues that patients face that need to be addressed as well. And then in terms of clinical trials, I think this is probably maybe an unmet need that's been actually addressed, that has been addressed and still is being addressed with getting better outcome measures and having stronger study designs so that we can actually have better treatments for cutaneous lupus in the future as well. So for that being said, I want to again thank everyone for their attention. And I think this is moving forward. I think we're going to have a little bit of time for question and answers as well. And so we'll start with that. And I think we're going off of questions are being put into the chat function. Is that correct as well? Or I think I'll be...
Yeah, there is a question on the chat.
Okay.
Should SLE patients with a very, very big leg ulcer, like pyoderma gangrenosum, and responsive to steroid cyclosporin, Imuran, make of IgA? That's a very tough question. You have, I really think you have to consider antiphospholipid syndrome in that case, because there are some pyoderma gangrenosum-like lesions in antiphospholipid syndromes. And then, in my experience, anti-IL-12/23, such as ustekinumab, may be very useful in refractory pyoderma gangrenosum, but this is not this is quite rare in the setting of SLE. So I think I will try I will try ustekinumab in that case.
So I guess in terms of non-healing ulcers in SLE, I think I agree with Dr. Chasset that kind of looking into whether the patient has a history of antiphospholipid syndrome would be actually important to look at as well. It might be also make sure that it's important to just get a good biopsy as well, and also tissue culture to make sure this is not a lingering infection that's also causing, sometimes you can have deep fungal, atypical mycobacterial infections that could cause
Absolutely.
ulcers as well. So especially for immunosuppressed patients, so you want to make sure that that's been ruled out as well. Um, and also other common things like venous stasis ulcers too, especially since patients sometimes could be a little bit compromised with their have vascular compromise in those areas as well too. So just a couple other things just to make sure you rule out too.
I fully agree.
All right. So what is your perspective on skin tapering for biomarker monitoring during clinical trials? I'm not sure I understand that question. Maybe you can explain a little bit more about skin tapering. Is that skin uh taping? All right, skin taping?
I think it is skin stripping.
Skin stripping? Skin
I
tape?
think
Tape
such as
stripping?
did Joe in the past.
Oh yes, tape stripping. Okay, I
Maybe.
think it's referring to tape stripping. So I actually don't have, I think that Dr. Chesney's mentioned a little bit. There's been some work done on tape stripping that's been done by our colleague, Dr. Marola, um, in actually finding biomarkers as well. And I think they've done a little bit of work to try to actually, I'm blanking on what specific findings he found, but I know that they've done a little bit of work on that, although I think there still needs to be a lot more work to be done in looking at potentially that. I think one um, area of focus that hasn't been looked at with tape stripping that has been used in other diseases is actually studying the microbiome as well, and that could be also of interest for study that could be done in cutaneous lupus as well. But I don't think we really know a lot about
No,
the use.
I think we don't know a lot about this, but for sure, tape stripping is less invasive than a skin biopsy, and for sure, it will be very interesting to have skin biomarkers with non-invasive techniques, and tape stripping is for sure one of potentially useful techniques. But we now have some interesting biomarkers in the blood as well, so. It will be interesting in the future to determine if there are correlations between the skin and the blood, and I think this is a very interesting area of interest in the future. In the blood, I think that we now have very interesting data about the interferon signature of some other way to monitor interferon that using some very interesting, very sensitive techniques such as digital ELISA, the CMOA, which has been used. With my teams in SLE, we demonstrated that monitoring interferon by CMOI is very interesting to prevent to determine the risk of relapse, and this will be very interesting.
Yeah, I know. I think you present some interesting data on that for interferon alpha. I think in particular could be actually a really interesting marker um, to correlate with skin disease activity as well. Um, so the next question I think is, should clinical trials be also looking at mast cell activation for CLE? Um,
This is
interesting.
a very tough question.
That's a really interesting question because I don't know if we've really seen mast cells really frequently seen in the pathology of cutaneous lupus. I don't think of it as something that we see. I don't think that's a cell that we see much in the pathology. So I don't know if it has been really looked at. Um, so it mentioned a paper on it from 2015. So what paper would that be? We'll certainly take a look at that in the future, but that's
No, what can
question.
I say is that there is a team from Paris actually who demonstrated that there are autoantibodies directed from IgE In lupus and IG are very strong interaction with mast cell. However, I don't think that targeting mast cell will be one of the most promising targets in CLE. Maybe I'm wrong, but I don't think this is the most promising target.
Thank you for sharing that paper. We'll take a look at that again.
No more questions?
Well, I think if there are no more questions, I again want to thank everyone for their attention and for attending. Again, I want to thank our speakers, Dr. Richardson and Dr. Chasset.
So we appreciate your attending this forum. I do hope that you understand the advances that are being made both on a clinical and research and therapeutic side of cutaneous lupus. This is really an exciting time for the field. Again, thank you for attending. And we would like to thank our sponsors, as you can see listed here. And your feedback is important to us. Thank you for your attendance. We hope you have enjoyed this webinar. Please fill in the short evaluation form to let us know your feedback and receive your accreditation certificate. And the live streaming version of this webinar will be available to view on YouTube channel, The Lupus Forum. Thank you very much.